and we'll have each of the seminars up. We'll have a flyer for each seminar, and you can register there. I just want to take a moment and thank Dr. DeYoung for being our speaker this morning. He serves as the Chief of Geriatrics for Capital Caring Health and the Medical Director at Vinson Hall Retirement Home. His main goal is to create skilled and affordable teams that help frail elders live with dignity at home. From 1999 to 2019, he was the Director of Geriatrics at MedStar Washington Hospital Center. He's on the teaching faculty with Johns Hopkins Medicine and graduated with honors from Stanford University and Yale School of Medicine. Welcome, Dr. DeYoung.
Thank you, Lisa. Good morning, everybody. I'm going to talk about dementia, over kind of the spectrum of illness, but I did want to make sure, please ask questions as we go along. It's kind of more fun to take questions as we go and have interaction. So you can interrupt me by putting your question into the chat box, and then Lisa or Ellen will help kind of field those questions. So as Lisa said, I'm a geriatrician. I'm an internal medicine doc. I'm interested in primary care for elders who have dementia, but also other illnesses. This is the outline of what I'm going to talk about today. And Lisa, can you see the slides okay? Okay. I'm going to have two case studies, one kind of an early stage dementia case and one more of a late stage dementia case. I'm going to go over the types of dementia because dementia is a big category. It includes many different types of dementia. Everyone hears about Alzheimer's, but there's a lot of other types that are less common. And we'll talk about a few of those. How do you make the diagnosis? Are there ways of either preventing or treating people with cognitive decline? How do you know if it's reversible or if it's not reversible? And then what are some of the hard decisions that occur later in the course of the illness? So the first case study is kind of more of an early stage case. This is an 83-year-old woman who has hypertension, history of breast cancer, anxiety, alcoholism, off and on throughout her life, and prolonged recent grief because her husband of 60 years died a couple years ago. She's had gradual cognitive decline. So before I go on, I just want you to think about this profile. And just think, what are the risk factors that this person has for dementia? She has hypertension, so vascular disease. She has some psychiatric issues. She's had breast cancer. She has grief and alcohol overuse. So lots of different risk factors for cognitive deficits, right? And then we'll talk about what that may mean for her. So her family report 2 to 3 years of short-term memory loss. But then recently, in the past 9 months, throughout the second half of the COVID epidemic, she's had worsening short-term. So there was no normalcy. Let me move the picture out of the way here. Short-term and very short-term memory. That means very recent things she has trouble remembering. So she has some impaired judgment. She frequently loses minor items around the house and had a few falls in the past 9 months. And her memory is clearly worse after she drinks excess of wine. Her family note, she's had loss of insight about this memory loss. She repeats her questions. She's unable to complete certain specific, minor tasks like writing, taking care of bills. And there's actually some old food that they have found kind of rotting in the refrigerator. But interestingly, she has very high function. She has very excellent social skills. She's intelligent. She reads, does puzzles, keeps her apartment very neat. So this mix of kind of some cognitive deficits, but some very high function as well. So a little bit hard. In fact, her primary care doctor didn't really think that she had significant dementia because of those social skills. Her family history is interesting that both her mom and her grandmother had dementia at the age of 85 to 90. So the story continues. She lives alone right now in a senior community, in a townhouse, kind of in a residential part of a senior community. Her supportive daughter lives about 2 miles away, and she has close friends and her own brother, an elderly brother who lived 3 to 4 blocks away. So a very supportive family and friend environment. She has a 4-hour health aide to kind of help with some meal preparation, help take her to errands, and do some shopping with her, which started about 6 months ago. So what is her functional status? The big thing about people with dementia is how are they functioning? So in this case, she's able to function pretty independently inside of the townhouse for basic activities. So walking, going to the bathroom, cleaning, hygiene, eating. She can do the basics pretty well independently. She needs assistance with some cooking because she has some apathy about cooking, and managing her remote control for the TV and managing her finances and doing shopping. Part of this is because of the intermittent alcohol issues she's had. She really wants to drive her car, but because of a couple witnessed WI events, she wasn't pulled over, but the family noticed that she had forgotten that she had drunk wine, and then she drove and had some impairment. So the family actually recently removed her car and her keys, and that's a big deal, right? You know, taking away the car and the keys from someone who's fairly high function can be stressful for all parties. Here's a few medications. You always want to look at the medication list that the person is on. Could the medications be causing some confusion? She's on mirtazapine, which is an antidepressant, atorvastatin for cholesterol, baby aspirin, vitamin D, and diltiazem, which is for blood pressure. So not a long medication list, but just have to think carefully about her meds. And so these are the questions that come up about a person with early stage dementia. You know, what's the diagnosis? What's causing it? What kind of dementia is it? Does she really truly have dementia? And what is the definition of that? Does she have decision-making capacity? Is she safe in her living environment? Is she taking her meds, or are her meds causing any problems with her mental status? And then if there are decisions about end-of-life care, which is what EOL stands for, what are her wishes and what are the goals of end-of-life care when she gets to that point? I'm going to stop there. Any questions about the case that have come in?
Nothing in the chat just yet. I guess I would just like to ask right here if you in terms of her wishes, I wonder if you could speak for a minute about things like the driving and what you would recommend about maybe having some of those kind of conversations early on and even before you get to those final wishes.
Yeah, so her very strong wishes right now are to stay in her home where she had lived with her husband, because she has a lot of nostalgia and memories of wants to be independent in her own place. Her daughter has offered to have her live with her, and she has declined that offer. So in terms of the key questions for her life, one is, where does she live and is she safe there? The one about driving is she actually lacks insight into the fact that she's been impaired when she drives. So that was a very difficult one for the family. And ultimately, because of safety, for her safety and safety of others, the family made the decision, again, taking some of her autonomy away to remove her keys and the car from the garage. She was not happy with that. She did not think that she was impaired. So this issue of mental capacity comes in. What capacity does she have to make decisions? She can make a number of decisions for herself during the course of the day, but there are decisions that the family had concerns that she lacked capacity. Some decision-making capacity comes up. And then but practically, how do you deal with that? You know, she's high functioning enough to know that you took her car and her keys, and she's upset about that.
Yeah.
And I'm sorry.
Oh, I'm sorry. Lisa, go ahead. And then we do have a question that came in on the chat, and I can read that after you make your comment, Lisa.
Okay, thank you. So my question too is, like, you know, some of these meds, I mean, is it easy, Dr. DeYoung, to move? I mean, are there some meds like for cholesterol or high blood pressure that are perhaps better than others? I mean, is that a common practice to look at what folks are taking and then try and decide if maybe something else might be better with the diagnosis of dementia?
Sure. So you have to think about what potentially is the underlying cause of the dementia. So if someone has vascular disease, meaning like their carotid artery is partially blocked, which in this case the person did have, if they've had a stroke, if they've had a heart attack, do they have vascular disease? Then you really want to make sure they're on that atorvastatin, the cholesterol medicine, and the baby aspirin, because then you're treating the underlying cause of the dementia.
Right.
Blood pressure medications are a really important decision point. You know, does she need blood pressure medicine? Number one, is she truly maintaining a high blood pressure? And then which one has the right side effect profile for someone with her illness and her age? So diltiazem is a fairly common one. It has relatively minimal side effects, but it can cause a slow heart rate. Other medicines are diuretics, and they can make people dehydrated and more confused. So you have to think carefully about which medication you use, depending on what the underlying cause of their dementia is.
Thank you.
That is so important. I'm so glad to hear you say that. I'm going to read the question from the chat. Many years ago, about 40 years ago, I was told my husband at the time was picking his brain with his excessive drinking. Pickling his brain with excessive drinking. Others at the time, the medical in particular, said that that was not possible. So destroying parts of the brain with alcohol was not possible. Thus, will excessive long use of alcohol do the equivalent of pickling the brain permanently?
That's a good question. So the short answer is that chronic excessive alcohol use can cause dementia. It can cause damage to certain specific parts of the brain, notably the hippocampus, which is where memory in particular, and the cerebellum, which controls gait and stability. So severe alcoholism can lead to both a dementia illness in the later years, but also can cause falls and gait immobility. So it is true that excessive long-term alcohol use is a cause of dementia. There are many people who drink excessively for many years and they don't get dementia. So it's not a guarantee that it will happen, but it certainly can contribute. And in this case, the excessive alcohol use, she also had high blood pressure and vascular disease. She also had anxiety and grief. And so she has a combination of things that may contribute to her cognitive troubles, but alcohol can contribute.
Thank you.
Any other questions?
Nothing else in the chat right now.
All right, so the first thing is to recognize the cognitive decline. You know, there's a lot of different changes as people get older. There's some just forgetfulness, and that doesn't qualify as, you know, dementia. People have age-associated memory impairment, and that doesn't mean you have dementia. You just are a little bit more forgetful of dates and times and people's names. But early phase of actual dementia, you'll start to see people have trouble with their medications, have short-term memory with a lot of repeated questions, losing items, keys, glasses, you know, important things around the home, and then having falls. And falls is a symptom of early dementia because people can use poor judgment if they don't realize that they forget that they're unstable or unsteady. They may not use their cane or their walker because they're forgetful that they need to use that. So these are some just the early signs of a more significant cognitive decline. And then to figure out what the cause is, you have to think about some key signs, like how fast did it come on? And we'll talk about that a little later, but some types of dementia come on quickly. Alzheimer's does not. It tends to be very slow and gradual, but speed of onset is important. The age that it starts, certain types of dementia start at generally at different ages. And so that's an important clue. The specific symptoms they have, there's dementia with, say, Parkinson's disease. You have to look for certain exact specific symptoms of the type of dementia. And then what other risk factors they have? What in their medical history would make you think that they have a certain type of dementia? The other key thing is to separate a dementia from acute confusion, often called delirium or just acute change in mental status. That is often reversible. So if somebody becomes acutely confused from their baseline and they, over the course of hours or days, they become confused, that does not mean they have dementia, and it often is reversible. But if it isn't acute, the big kind of symptoms of dementia syndromes are memory loss, usually short-term memory loss in particular. And then these 3 A's, and these are medical words, but I kind of give a little definition. Aphasia, which is trouble with word finding or naming objects. Apraxia, which is ability to like button your shirt. You kind of forgot how to do small tasks in your life. Or agnosia, not recognizing people, places, or things. So you don't have to have those, but those can be a sign of, in addition to memory. And then the third one, which I see a lot of in the very elderly population, is executive function. Their ability to form and carry out a plan, go to the store, get the groceries, and bring them back. Bathing and showering is a very common loss of executive function of doing specific plans. So generally, those are the 3 big areas of a dementia syndrome. And the general definition, and I like this because it's simple, but it also captures a lot, is progressive deterioration in cognitive function that affects your life. So some people can have some memory decline, but it doesn't affect their life. And it only is when it really affects your life that people qualify for the diagnosis of dementia. So now this table is a little complicated, but I just wanted to show what are some reversible, I'm going to move my, so about 10% roughly, and this is, it varies, of cognitive changes and confusion can be reversible. So here's just a number of, there's a lot of them, right? You can be really acutely confused from a stroke or drug intoxication, and then there's a few other more rare ones that I put below. So I put the common ones in bold at the top. Subacute means it's happened over the course of weeks. It's still pretty fast. So you're getting confusion or change in mental status fairly quickly. It would really argue against something like Alzheimer's disease. And things like a subdural bleed, that's a bleeding, someone fell 2 weeks ago, like someone with alcohol problems and falls. And then over a couple weeks, they get confused or they're not themselves. That can be due to a subdural bleed just below the skull. Things like high calcium or high sodium from other illnesses can be a kind of silent cause of confusion, but you have to get blood tests to make sure you rule that out. And then there's some chronic causes of cognitive decline or what looks like dementia. Severe depression can mimic dementia. People have trouble with memory, concentration, self-care, self-neglect, and that can be from just a profound depression. And again, this patient had grief and anxiety with some depressed mood, and so that could worsen the symptoms. Low or high thyroid both can mimic, again, a dementia syndrome, as can some of these other more rare things below. But I just want to highlight this, that the key to the team taking care of a patient with confusion or what you think is dementia is to make sure they don't have a reversible one. And there are a lot of them, so you have to kind of do a careful physical exam, some blood tests, a careful history of for trauma or infection, and rule out these reversible causes. I'm going to stop there and just see if anyone has questions, because this is, I think, something that isn't always known out in the lay world, that there actually are reversible causes of cognitive decline.
Feel free to put a question in the chat right now if you have any questions. Or certainly unmute yourself and ask a question. That's certainly okay as well.
All right, so these are the reversible causes, and it's not an exhaustive list, but these are the common ones, especially the ones in bold at the top that doctors have to really think about if someone comes in with new confusion. So now let's talk about the more non-reversible. And you hear about medications used for Alzheimer's at times, but in generally these diseases are not reversible. There is a small proportion who might benefit from medications, and we can talk about that, but it's generally not reversible. And that's about 90% of people who present with cognitive deficits. So this is, again, a kind of a busy slide, but I just wanted to give you one place in the team here, I think, can make my slides available to you. And Ellen and Lisa, I did update these slides even this morning, so I will send you the final version of these before you distribute them at the end of the talk.
Great, thank you.
So the one you hear about a lot is Alzheimer's disease. But as you can see in the left column, that's only about 60% of dementia types. So if you have 100 people with dementia, 60 to 70 might have just true Alzheimer's disease, but another 30 to 40% are going to have some other type of non-reversible dementia. And I put here the keys to kind of diagnosis. On the left, again, on the left column, you can see these are the 6 that are that we doctors think about as the more common causes of dementia. There are some even more rare things. You may have heard of prion disease, but there's exceedingly rare causes. But these are the most common ones. So vascular, small strokes or large strokes can cause dementia. Parkinson's disease has a significant rate of dementia later in the disease. There's something called Lewy body, which we'll talk about in terms of it's related to, it's a kind of a cousin of Alzheimer's, but it presents differently. Alcoholism, as we talked about, can cause a certain syndrome of dementia. And then there's a very interesting and sad type of dementia called frontotemporal dementia, which has very characteristic qualities that are quite different from Alzheimer's. So just kind of go through, just if you're thinking about the history of the patient, what's some of the keys to diagnosis? In general, Alzheimer's affects people much more who are very elderly. There's a rare early onset Alzheimer's. Sometimes people in their 60s can get it, but it's very rare. It tends to be age over 70 to 75 when it starts. Very much more common in people in their 80s and their 90s. It's slow in onset, primarily short-term memory. It's gradual. Occurs over 10 to 15 years from onset to death. People can generally be intact in terms of walking and talking and getting around. So they can wander, they can want to drive, their motor function is quite intact. And they often have a positive family history with no other risk factors for dementia. So they don't have diabetes and hypertension and strokes. They really have very few medications and very few other illnesses except for these symptoms. Vascular disease, by contrast, they often have a lot of risk factors for vascular disease, poor circulation to the brain. They again have had strokes. It can go at a faster rate because if you get a stroke, it happens suddenly and you can get deficits very quickly. They often are more slowed in their motor function, and MRIs can be helpful in terms of diagnosing the vascular disease. Less so in Alzheimer's, which does not have a characteristic MRI finding as much. Parkinson's disease is interesting in that you can get significant cognitive deficits in a dementia, but it's later in Parkinson's. You will have seen on the physical exam tremor, slowed movement, stoop posture. You will see Parkinson's symptoms for many years, usually before they have dementia. Lewy body is a kind of a classic board question for medical students and doctors, but it does happen, and it's probably a little less than 5% of dementias that we see. Tends to occur in younger people, often in their 60s and 70s. They get visual hallucinations. They look like they have Parkinson's disease, but they don't. They have kind of slowed movements and sometimes a tremor, but it's not true Parkinson's, and they have frequent falls. Alcoholism, as we talked about, often affects primarily the very short-term memory. They often lack insight or have denial about things. Falls, they have the overuse history of alcohol. They often have weight loss because they're drinking instead of eating, and they can have chronic liver disease. So those are the clues for alcohol-related dementia. And finally, frontotemporal dementia. Again, it occurs often in people in their 60s and 70s, a little bit younger onset than Alzheimer's. They have disinhibited behavior. So the front part of the brain and the temporal part of the brain control behavior and emotion. So they can have delusions, emotional kind of paranoia, but physically they're quite intact. So they can be very difficult to care for because they can walk and talk and have sometimes excessive physical motion because they're disinhibited. So I'm going to stop there just before I go on and see if there are any questions about the categories of dementia or how to try to make the diagnosis.
Nothing in the chat at the moment. Does anybody have any questions?
I have a quick question about Alzheimer's. Can it, like my dad was diagnosed with Alzheimer's, and it was longer than 15 years that we noticed behavioral changes, things like climbing a tree with a chainsaw, I mean, just things that he should have known not to do. So could it even be longer than that, perhaps, for some people?
Sure. I think 10 to 15 is kind of the average.
Okay.
I have also had patients who have had changes in their cognitive function for 20 years. It'd be surprising for it to last more than 20 years if it's true Alzheimer's disease. You really don't know it's truly Alzheimer's. And sometimes, for example, you can have microvascular disease that presents, but then it's stable for a long time because they don't have another stroke or they don't have other vascular progression of their disease. So there's a mixed dementia of Alzheimer's with vascular. And you only really know that when people die, if you were to do a biopsy or an autopsy of their brain to kind of prove that they truly had the Alzheimer's pathology. So if someone is stable for many years, I start to question that it's truly Alzheimer's. And I think maybe they've had some microvascular disease that is stable.
Thank you.
I think that's another interesting point, that people can have more than one of these dementias at one time.
Well, think of this patient. So this patient had significant alcohol use for many decades, and it's still not well controlled. She has psychiatric issues with anxiety and depression. She has vascular risk factors for hypertension and carotid disease, and she has a family history of mom and grandmother of what appeared to be Alzheimer's disease. So she probably has a mixed cause of her mild dementia.
Mm-hmm.
So that gets to the treatment. When you have a mixed picture, you kind of want to treat everything. You want to treat to prevent stroke. You want to treat the psychiatric issues. You want to treat the grief. You want to treat if there is any potential Alzheimer's treatment, although often it's not a drug as much as social and physical and intellectual stimulation. But you kind of want to treat everything with the kitchen sink when you have a mixed picture.
And that was another question I had, Dr. DeYoung, with regard to medications. So for those different types of dementia, or what comes under that category, I guess medications are going to vary as far as their effectiveness.
Right, and you're going to try to go at the root cause of what you think is the most likely cause, the primary cause of their dementia. You may all know, but the Alzheimer's meds that have been given for the last 20 years are relatively ineffective. They only benefit when they've studied them in the real world, also in the studies, maybe 1 out of 10 patients who get those medications have any noticeable benefit. So generally, I have not found them to be very effective, but that's why I'm really aggressive about treating depression and vascular disease, because we do have medications that are really quite effective for vascular disease and depression. And so if you treat those, if you think that's part of the picture and you treat those, you can often see a significant improvement in the patient.
I had a question. You talked about the Alzheimer's drugs, have been around for a long time. I think I just saw an article on a new Alzheimer's drug. Is that?
Yeah. So that's
differently.
I thought someone would bring that up. So it was yesterday. There's a drug that's called it's an IV drug it's an antibody. It's like a monoclonal antibody, fancy new drug through the IV that a company called Biogen did some studies on, and there's a great article actually in today's New York Times about the FDA action from yesterday's front page article on New York Times. I encourage you all to read it because the drug is really overhyped, and the scientific advisory panel a few months ago recommended it not be approved because it did not have convincing evidence of benefit. Now, interestingly, a number of patient advocacy Alzheimer's advocacy groups and a few doctors, but not the majority of doctors, encouraged FDA to approve it. So they did approve the drug yesterday for treatment of early Alzheimer's disease because it reduces what's called amyloid plaques in the brain. And the thought is that amyloid deposition in the brain leads to Alzheimer's disease. However, I'm really shocked, honestly, that the FDA approved it. They kind of gave a conditional approval and they want to study it more. But now that the horse is out of the barn and patients and families are going to be requesting this medication, one of the things is that the risks of that medication, 40% of the patients who received it had brain bleeding or edema of the brain. 40%. And that means they have to do regular brain CT scans on, I don't know if it's monthly or quarterly basis while you're on the medication. So you have to get regular CAT scans. 40% of folks had some sort of brain hemorrhage or swelling. And the level of benefit, there were 2 trials of the drug. One trial showed no benefit, and another trial showed a very minor benefit. So I'm surprised the FDA approved it based on everything I've heard about it, but they did it on kind of a compassionate basis because we don't have anything else really effective, and so they decided to let it out into the market.
That's too bad.
I think it raises false hope.
Exactly. That's just what I was going to say. It just feels like it's false hope for people. So that's, yeah.
Expensive.
And I heard a comment this morning, Dr. DeYoung, on the news, and I guess it was an advocate for that who was a higher up individual and said that, well, if it didn't work and they found that it didn't work, they would just take it back off the market. Right. And I thought to myself, wow, I mean, that is just, I mean, how much damage could be done prior to that moment? You know, how many people could be affected by that, you know?
Yeah, I'm actually really, I'm deeply disagree with the fact that they approved it based on what all the really experts, neurology and Alzheimer's and dementia experts who reviewed the data said beforehand. And they did it for that reason, what you just said, Lisa, that, well, let's give it a try. And if it turns out to cause harm, then we'll take it off the market. Well, the #1 rule of medicine is to do no harm.
Right.
Okay.
I
Yes,
had a
go
question.
ahead.
So I was just kind of wondering, because you're talking about how important it is to treat depression when you're trying to lessen the impact of Alzheimer's. I was kind of wondering if earlier in life, like depression and anxiety disorders, can that contribute to having Alzheimer's later in life?
You know, I think that I haven't seen any evidence of that if you have depression or anxiety, it contributes to actual Alzheimer's. It can contribute to struggles with your memory and your concentration and your mood and your self-care, but it doesn't actually have a higher predisposition to getting true Alzheimer's disease.
We do have a question. Thank you. Thanks for that question, Angelina. And Renee, thanks for bringing up the new drug. I saw that article this morning. I didn't get a chance to read it, but I was like, oh my gosh. We have a question in the chat. What is the name of the new medication?
It's called, I have it here in front of me. It's called Aduhelm, ADUHELM is the kind of commercial name, and it's a monthly IV infusion. And the Times science writer did a really good job of depicting both sides of the story, and it actually quotes a lot of specialists saying they're not going to offer it, but they'll be in they may be in conflict with patients and families who want to try it. So I would feel comfortable personally telling people I think the risks outweigh the benefits, and I'm not sure that I would personally offer it myself.
I know, yeah, I feel like we've been down that road before with some of the medications. I know years ago, my dad too had been diagnosed with Alzheimer's, and one of his other medical symptoms was he had terrible gastrointestinal problems. And then one of the drugs, I think it was Aricept at the time, and you know, they talked about putting him on that, and we were like, I worked at the Alzheimer's Association for many years, and I knew that Aricept, you know, could cause some gastrointestinal problems, and we were like, oh my gosh, that would be the worst thing for him. It just feels like a lot of times people are like ready, like you say, they're ready to jump. It's in some ways it's false hope. They want to try anything, but sometimes not realizing that, like any medication, these drugs have side effects, and sometimes they can be very serious for people, the side effects.
Good point.
Okay.
So I find it much more compelling to talk to people about prevention or slowing down the progression of dementia. And so I put here just a little table together. On the left are lifelong risk factors for developing dementia. And this gets to Angelina's question about what you can do to prevent dementia. And there's some really great evidence, long studies, 10, 20, 30-year studies of what your life risk factors are for getting dementia. Dementia really of any type, especially vascular and Alzheimer's. So smoking and excess alcohol. So the way to prevent that is to not smoke and not do excess alcohol. Low education and socioeconomic status is really fascinating because you can think of it as building up the brain reserves with education and good self-care and social, intellectual, physical activity really prolongs the onset, defers, pushes off the onset of cognitive decline because you have increased your brain reserve. There's some great studies of nuns in the convents when they were 20, 25 years old, and those who had much more advanced education and intellectual and cognitive function in their 20s had a lower rate of dementia in their 80s. So stay in school and keep working and try to really maintain, both from a social and policy perspective and a personal perspective, your education and kind of socioeconomic status. Sedentary and obesity. There's a direct correlation between sedentary lifestyle, obesity, and cognitive decline. So again, exercising, staying active and fit in whatever way you can do that is a great preventive measure. Vascular disease is probably the most the most impact you can have on preventing cognitive decline is to really pay attention to prevent vascular disease. And that's to, if you have diabetes, really have it be well controlled, but avoid it if at all possible, so that, and avoid weight gain. Keeping your LDL low, not smoking, staying fit and exercising regularly, and that really can prolong and prevent the vascular component that contributes to dementia. And family history is a little just humor. You have to choose your parents well, and you don't have a choice in that, but family history does play a significant role.
Can you just for a second define excess alcohol? I've had a lot of questions about that. Well, what's excess? Can you have a drink every night? Can you have two?
Yeah, so in general, I think the medical definition tends to be more than 7 drinks a week. 7 to 14 is kind of the gray zone. My impression is that a single glass of wine or drink per night is not going to cause acute medical problems or long-term medical problems. But once you get up to 2 or 3 or more, that's when we start to see significant both acute and also long-term medical problems.
Thank you.
And it's a great question. Some people can handle their alcohol much better than others. And so it depends on the effect of the alcohol on that person. I just want to mention just losses. In the mild and moderate stages, and this case kind of describes this, there are just a buildup of losses. You lose recent memories or ability to kind of enjoy kind of recent memories. You lose certain activities that you're used to doing on your own. Your personality may change, or others may notice a personality change, and that can affect relationships. And you can lose some of your freedom. In this case, the person lost their driving ability. There's other autonomy that people may lose in terms of managing their finances or doing social activities. And so there's this buildup of losses over time. And then in the more severe stages, the losses are more, profound and striking, right? They can lose physical function. They are unable to walk or transfer or get out of bed. Certainly the IADLs, which are the independent activities like shopping and using the phone and cooking. And so they lose a lot of their physical function. Bladder and bowel control ultimately decline so that people become incontinent. Speech at the end stages declines, and that's one of the kind of criteria for hospice care actually, is when people become more nonverbal. And swallowing, the ultimate end stage, both Alzheimer's and vascular dementia and some of the others, is people stop swallowing. And then that becomes more of a decision about end of life care. So what are the hard decisions for this patient we described? So one hard decision is, when does a family or the POA take over as the power of attorney and serve as decision maker for which decisions? Do you let the patient make some decisions, but essentially reserve authority to make other decisions? In this case, the car was a good example. Home safety and living may become a question. And I think ultimately you need to have the documentation of who would be that POA, and then usually in most states, 2 physicians need to document that the patient has now lost mental capacity, and so the POA is activated. When to stop driving. I thought this case was not open and shut, but fairly clear that once a person is unaware that they're driving while impaired and lack insight and self-control, that's a point at which you can stop a person from driving. When do you have the person move in with family or an ALF? What if they don't want to? What if they want to live independently, which is a strong inclination of many elders? And how do you balance autonomy for them to live alone with moving in or taking more help in the home? And often that's a path of less resistance, is to have people accept a little bit of help in the home as opposed to moving out of their own home. And then what happens as people are getting more ill? What happens when they lose weight or stop eating? And what I've found over and over again is the weight loss in mild to moderate stages of dementia is not a sign of terminal disease. It's a sign of social isolation. They lose their interest or ability to cook for themselves. And the best intervention, and this occurred in this case, was hiring a home health aide or a family member being present to socialize with them, eat with them, cook with them, and really make sure they have access to all the nutrition. And I let my patients kind of eat whatever they want at this stage, because the pleasure of eating is important enough to them, and also helps keep them from losing weight. Now, there are other cases where people stop eating, and I have a case I'm going to describe where is more the terminal phase, but most of the times weight loss and decreased eating is due to the apathy and kind of early memory and executive function loss. And then finally, when are they ready for hospice? From looking at this case, she is clearly not at a hospice stage of her disease. She's highly functional in many ways, and still has a fairly high quality of life. So we're going to talk about a case, and we have about 15 minutes left. So I want to talk about another case that depicts more the late and terminal stages of dementia. This is Mrs. B, and she's kind of a mix of a couple patients that I've had recently to describe this phase. So she's 90 years old, again, older. She has hypertension, right? So risk of vascular disease. She's had 2, quote, small strokes that we know of. Has depression, and depression is often a result of vascular dementia. People with vascular dementia have a much higher rate of apathy and depression from the actual effects of the poor circulation on their brain. Frequent falls. She's had dementia now for 7 years, but again, not the prolonged 10 to 15 years that you would expect of an Alzheimer's case. But her family now in A's report decreased oral intake and a nonverbal state in the past, it was a couple months. So 2 months of functional decline, so more of a subacute, somewhat rapid decline, weight loss during the course of this 2 months, decreased speech, stopped walking. So, I know you all are mostly lay people, but what do you think is happening here? So why is there this fairly rapid decline in this patient? Any guesses? So some of the possibilities.
Oh, we have something in the chat here.
Go ahead.
Body shutting down question.
Yeah, so like, is she just got to the point where the burden of her vascular disease, her depression, her falls, her age, her weakness, is she just reaching the end game of her dementia, and she's declining? She lost motivation to eat, and she's lost the mental capacity to kind of direct her kind of functions, and is she just in the terminal phase? I think that's a really likely possibility. She's had a long course already, and she has significant vascular disease. Another possibility is that she's had a new stroke. She's had another stroke that kind of knocked her down. So this is that kind of stepwise decline that you can see in vascular dementia, where someone is stable for a while, and then boom, they kind of decline in a more significant stepwise fashion. And so I thought about that when this occurred as well. Depression can be a sign of actually this kind of decline. So I often think you want to do a trial of an antidepressant when someone has kind of a fairly subacute worsening of their cognitive status, but they may not communicate that they're depressed. We did a trial of that. Her mentation actually worsened with more confusion and less oral intake, and so we had to pull back from that medication. Her social life is that she lives with a 95-year-old husband who's on hospice already. She was not on hospice yet. They have 24/7 aides because they have a lot of private resources, and they have 4 children who live all around the country. So then the real question here is not so much, well, once you do some basic tests to rule out an infection, to try to rule out depression, think about a stroke, is what are the goals of this person? And so she had a clear POA. One of her kids was a medical POA, so she lacked capacity. So then we go to that POA for decisions. And they said her goals were always to, at this stage, to not go to the hospital, to stay at home and have no invasive tubes like a feeding tube or ventilator or machines. And so it was pretty clear, made it in some ways easy for the team, the medical team, to know what the goals were and to try to work with that. So what did we do? We got a weekend call, that around that time, that she's, quote, not eating or drinking at all, and she's kind of gone to bed. She's kind of shutting down, as one of the kind of attendees mentioned. So we did an urgent home hospice referral based on the goals, which allowed her in the next week, because she was quite unstable, to get some daily RN visits from the hospice nurse. Our house call NP visited a couple times. I had 3 or 4 calls with the POA to clarify medications and goals. The goals continue to be to stay at home, keep her comfortable, and minimize suffering. And what's interesting then in the next week is this, again, was a fairly rapid course, which you don't always see it this fast. The family all came in from all around the country. The comfort kit was present from the hospice team, which includes a variety of medications for different symptoms at the end of life. Hers were more moaning and seeming to be in some pain and distress, so we increased her morphine dose to every couple hours. Actually, I wrote here 6. So all 4 children, that's a typo, were present on a Saturday. They all had their hands on her, as it turns out, and she died with her family at her bedside about 7 days after the home hospice referral. And then on Sunday, since it was actually a Jewish family and they were interested in a rapid funeral per their religious faith, we got some assistance. We were able to get the death certificate done within 24 hours on the weekend. So I thought this was a good example of a family and a patient that had really thought carefully about what the goals were. They had access to good, both primary care at home through our house call program. They also had access to good hospice care from Capital Caring Health. And I was amazed. All the children were present and had their hands on her when she died. So they ended up feeling like it was a really beautiful experience that weekend. Any questions about that case? So that's the other end of the spectrum.
Well, we do have a couple of comments and questions that came in. I'm not sure specifically related, but we can open it up to others as well. Virginia says it's very difficult, often surprising for loved ones to deal with someone who uses his high level of education in a mentally challenging vocation, but who is diagnosed with Alzheimer's.
Mm-hmm. No, that's a good point. It reminds me a little bit of the first case. You have people who are highly intelligent and highly functioning, and they want to hold on to that function. They want to hold on to their authority and autonomy and what they want to do with their life. And it is challenging when they suffer from memory or judgment or executive functions, and you have to take some of their autonomy away. So it can be a struggle. There's no easy way around that other than to try to find a balance of, what I try to do is give enough autonomy and freedom in some things that I feel like they can do safely, but really make sure the POA is empowered to make decisions when they are not safe.
That's a really good point. I know a lot of times too, we talk about validation and validating, feelings, and that can sort of de-escalate sometimes some of that challenging behavior. We have another comment actually from Virginia as well. This one probably could be the topic of a whole nother session, but I'm going to go ahead and read it out. Why do we think everyone should live forever or be kept alive no matter what their physical, mental condition? So
yeah, I mean, that's a big topic, but it's also I'm a geriatrician, so I kind of agree with the general tone of the question. And I thought this last case was a good example. It was, I find the cases, and just for me personally, I've been doing this for 25 years now. And when patients and families recognize that death is a part of life and that they want to be at home and be with family, and this actually was a beautiful way for her to go. So I think people have to accept that we may not be able to fix everything, and they really have to think about where they want to be when that moment comes. But it's hard. People have a lot of denial and a lot of resistance to losing their life. An old mentor of mine used to say, the appearance of the bull changes when you enter the ring. So when you're in that situation, it's a little harder to decide you're just going to let go, or the family may find it hard to let go. But theoretically, it's something that I hope people can think about.
Great point. Thank you. And thank you for the question.
All right, so I'm just going to go to almost the last slide or two here, just in terms of when someone's eligible for hospice care. And these are kind of more Medicare guidelines, but it falls into 4 major areas you have to kind of assess the patient for. Their functional status, and they need to be totally dependent in their activities of daily life. That means transferring, toileting, etc. Verbal and speech, basically, I don't know how they picked this, but it's less than 7 clear, coherent words or phrases, and that helps get you points for qualifying for hospice under Medicare. Incontinence of bladder and bowel, and then at least one of these clinical complications needs to have occurred. Aspiration pneumonia, significant weight loss, again, that's not reversible, a pressure ulcer, or recurrent infection. So if you have this picture, then you qualify for hospice under the Medicare benefit. So that's kind of the end of my content about the dementia. I was just going to give one slide
I'll be
about.
back in a minute. Okay.
I was going to give one slide about our primary care at home program that we have here at Capital Caring Health. But before I go on to that, any other questions about the progression or the spectrum of dementia?
Nothing in the chat right now.
I have a quick question, Dr. DeYoung. It's just with regard to what I've noticed over probably the last 10 years or so is that so many medications have come out, and you see them, they are advertised on TV, which then in turn causes the patient to go to the doctor and ask for these. So what I see a lot in my line of work is that people come in and they're on 10 or 15 medications. And my question to you is, is it possible that the side effects from this mix of all these different medications that people are on which in many cases is a good thing to have. It's good that we have medication. I'm not saying that, but I'm just wondering how that might affect people and if that could potentially be a cause for dementia.
Right. So the short answer is yes. Medications, when we get what we call polypharmacy, 10 or 15 meds, can cause cognitive decline. I wouldn't say it causes dementia because it's reversible, right?
Okay.
Dementia tends to be not reversible, but the combination of 10 or 15 meds can almost always causes side effects in a frail elderly person that I think are preventable. So I find my patients do better from a mental status perspective, physical perspective, when I can get them on the least number of medications possible. So my goal is often to reduce their med list in half. And usually they don't need all of those meds, but they've accumulated them from many different specialists or
right.
families, or patients desperately wanting to try to take a lot of different things. Mm-hmm. And I think it's a mistake to overprescribe that way.
Mm-hmm.
There's also, I think that's a really great point. I know when I was studying gerontology, we learned about something called the Bears list. I think it was called
the Bears list, right?
Bears list, which I think listed medications that were typically not appropriate for older adults. Is that something you would recommend people looking at, or what
yeah, you can look at it. The Beers list is a huge list, Ellen. It's got hundreds and hundreds of medications, and they categorize them by as kind of low, medium, and high risk. So it's not that you would never give those meds, but you have to be really cautious about the high risk medications, and then really customize the person's med list based on what they really need in terms, they may have serious heart disease or serious diabetes, and you may use some of these meds. Again, I do a lower dose, and I'm really cautious about how many of them I use. But there's shorter kind of versions, then the Beers list, if you look it up, there are many pages and hundreds of medications that you have to wait through. So that's more for a medical provider to look through.
Gotcha. Thank you. We do have one question in the chat.
Okay, go ahead.
Which is what percentage of people who live to 94 have some form of dementia? And we used to say about 1 in 2. Is that correct?
Yeah. So the short answer is it depends on what data you look at, but 40 to 50% of people over the age of 90 would qualify for dementia. That can be mild, moderate, severe. It can be any one of those types that we talked about, but it gets to 40 to 50% of people after the age of 90. I'm just going to close with this little list here of who we take care of at Capital Caring in the Primary Care at Home program. We really focus on elders with serious chronic illness, advanced illness like dementia, heart failure, stroke, diabetes, cancer, often a combination of those things. They do need to be home limited for either physical, cognitive, social, or psychiatric reasons, and live in the zip codes. And you can check out our zip codes on the Capital Caring website. And we do ask, they be open to a new primary care team, because we like to kind of take full responsibility for the patient. I'm going to close with this quote. I thought this was nice. It was from some of the literature I reviewed for this talk, that life with dementia can be less than ideal. Can't argue with that, but still be pretty good. And you can still maintain quality of life for folks at every stage of dementia, even though it's less than ideal. And I like this first website, the second bullet here. University of Arizona, as Center on Aging, has done a great website for caregivers, in addition to medical providers, about how to manage a whole variety of things in geriatrics. So I would encourage folks, and maybe I'll again share this slide. You can share it on the chat box. It's U of AZ, centeronaging.com. And then there's one for care partners. And I think it's a great resource for the community. Thank you for your attention. I think we're at the top of the hour.
Wonderful. Yes, thank you. I can't thank you enough. That was one of the best presentations on dementia and Alzheimer's I've ever heard. So
good.
It was. Thank you.
And yeah, I think that was really excellent. Oh, there's something in the chat. Let me just see. So incredibly helpful. Yeah. So I would echo that. Really great. As Dr. Jonge mentioned, we can share the slides on the Aging Together website. And is it okay to share? We have recorded this. Is it okay to share the recording?
Sure.
Great. Okay. Well, there you go. So if you know people that would be interested but missed it, they can hear it. Lisa, any last words?
Just don't forget to join us for our next webinar, which again, just to remind you, is on June the 22nd, and it's going to be on compassion fatigue for caregivers. So I think that's going to be excellent.
Thanks, everybody.
Thanks,
Lisa.
Thanks, Ellen.
Lisa,
thanks,
for pulling
everybody.
it all together. She's amazing. Thank you. Bye-bye.
Thanks, Lisa. Thanks, Corey.
Thank you.